بسم الله الرحمن الرحيم. عنوان المحاضرة بتاعتنا هو التونسيلايتس and the adenoids، اللي هو الالتهابات والتضخم في اللوز واللحمية. My name is Dr. Mohamed Amer. I'm an assistant professor of otorhinolaryngology in Tanta University Department. Starting with the tonsillitis, for a definition, it's an inflammation of the tonsils, and it falls into one of the main types, maybe acute tonsillitis or chronic tonsillitis. For acute tonsillitis, it might be acute catarrh, or we can call it in another word the superficial tonsillitis. Here, the tonsils is inflamed as a part of the generalized pharyngitis, and it's seen in the viral infection. Also, another type, which is the commonest type, it's the acute follicular tonsillitis, in which the tonsil crypts become filled with purulent materials. You can detect on examination white dots affecting mainly the medial surface of the tonsil, and hence in the name it's called acute follicular tonsillitis. Another type, it's the acute parenchymatous tonsillitis, and here the tonsils are uniformly enlarged and red. And the last types for the acute tonsillitis is the acute membranous tonsillitis, where here the infection forms exudate in the crypts of the tonsil that coalesce and accumulate together to form like a membrane which is attached to the medial surface of the tonsils. As we can see in some photos like this one, it's the acute membranous tonsillitis, and we can detect here the inflammation that form a pseudomembrane that is attached to the medial surface of the tonsils, and that makes the acute membranous tonsillitis should be differentiated from the diphtheria and other infection that forms a membrane attached to the tonsil. Another evident photo for the acute follicular tonsillitis. Here the infection forms follicles of pus due to separation and purulence of the tonsillar crypts, as we can see mainly on the right side. And here's a photo for the acute parenchymatous tonsillitis. And here another photo for the acute catarrhal tonsillitis. We can detect the diffuse inflammation of the whole pharynx, of the tonsils, of the uvula, of the soft palate, and it is a part of the generalized pharyngitis as we mentioned before. The etiology, it affects the school-age children, but adults can also be affected. It is rare in infants below the age of 1 year, and it is less commonly to be encountered in patients after the age of 50. Group A beta hemolytic streptococci represent the most common causative organism for the acute tonsillitis, followed by the Haemophilus influenza and the Streptococcus pneumoniae and the Staphylococci. For the symptoms, there is sore throat, difficulty in the swallowing, the pain in the throat, fever that can be accompanied by rigors and chills, earache, headache, and generalized body fatigue. For the signs, the breath is fetid and the tongue is coated. There is hyperemia of the pillars and the soft palate in the uvula, red and swollen tonsils with yellowish spots in the crypts that form the follicular tonsillitis, might be membranous tonsillitis, and here the separation form a pseudomembrane attached to the medial surface of the tonsil, or the tonsil is affected as apart from the whole pharyngitis, as the case of the catarrhal tonsillitis, or maybe a kind of parenchymatous tonsillitis. Also, we can detect the enlarged jugular-digastric lymph nodes as secondary to the infection of the tonsil. Treatment starts with bed rest, plenty of fluids, analgesics, and antimicrobial treatment that should be continued for 7 to 10 days. And here we recommend antimicrobial treatment that cover the most common causative organism, the beta hemolytic streptococci. Complication may be chronic tonsillitis in case of the recurrent acute attacks or improper treatment, or if there is persistence of the causes. It might develop into peritonsillar abscess or quinsy, paropharyngeal abscess, cervical abscess, acute otitis media, rheumatic fever, acute glomerulonephritis, and subacute bacterial endocarditis. It should be differentiated from the diphtheria, which is a kind of throat infection caused by the Corynebacterium diphtherium. It's also one of the causative organisms of the membranous infection of the throat. Also, the infectious mononucleosis that's caused by the Epstein-Barr virus, and from the other causes of malignancy causing enlargement of the tonsil, like the lymphoma and the leukemia. If there is persistence of the acute tonsillitis, it might develop into the chronic tonsillitis, which might be chronic follicular tonsillitis, chronic parenchymatous tonsillitis, and chronic fibroid tonsillitis. The chronic tonsillitis might develop secondary to the complication of the acute tonsillitis with recurrent attacks, or subclinical infection of the tonsils without acute attack, or it's a chronic infection of the sinuses or the teeth may be one of the predisposing factors causing the chronic tonsillitis. For the clinical features, there is recurrent attacks of the acute tonsillitis, there is chronic irritation in the throat and the cough, there is bad taste in the mouth and full breath, which is called the halitosis. The treatment of the chronic tonsillitis starts with the conservative management with attention to the diet and general health and the treatment of any predisposing factors like the sinuses infection or the teeth infection, and preparing the patient for the surgical treatment, which is called tonsillectomy. So the main line for the treatment of the chronic tonsillitis is surgical with removal of the tonsil or tonsillectomy. What's the adenoid? The adenoid, it's the nasopharyngeal tonsils. It's accumulation of lymphoid tissue at the junction of the posterior wall and the roof of the nasopharynx. It's composed of lymphoid tissue covered by columnar epithelium. It's present at birth, and physiologically it enlarges up to the age of 6 years, and then it starts to regress to disappear completely by the age of 20 years. The enlargement of the adenoid is caused by the recurrent attacks of rhinitis and tonsillitis and sinusitis, and it causes adenoidal hyperplasia. Patients suffering the adenoid hypertrophy may be suffering from nasal obstruction, mouth breathing, nasal discharge, and what's called the adenoid features. It is a special features of the face developed over time due to the nasal obstruction of the patient suffering from the adenoid hypertrophy, including the elongated face, dull expression, the continuous nasal discharge, open mouth, hitched up upper lip, prominent and overcrowded upper teeth, and high arched palate. Also, the patient is suffering from pulmonary hypertension due to the continuous respiration against high resistance. You can confirm the diagnosis of the adenoid hypertrophy through the introduction of the nasopharyngoscope, which is an endoscope introduced from the patient nostril and get to proceed into the nasopharynx where you detect the adenoid hypertrophy. Also, the X-ray may be very beneficial in detection of the adenoidal shadow. For the treatment, when the symptoms are not severe, decongestant nasal drops and antihistaminics is the treatment of choice. If there is marked enlargement of the adenoid up to the level that it interferes with the proper nasal breathing, then the adenoidectomy and the surgical removal is the management of choice. One of the most important topics in the ENT curriculum is the tonsillectomy operation, starting with the indications or what's called دواعي الاستئصال. Indications for the tonsillectomy, starting with local indications: if there is recurrent infection more than 5 times per year, if there is peritonsillar abscess formation, if there is detected chronic tonsillitis, if there is any suspicion or possibility of the malignancy of the tonsils, including the lymphoma or the leukemia, if the patient is suffering from disturbed sleep like the sleep apnea, and if there is marked enlargement to interfere with the proper breathing or proper deglutition. The other indication is called the focal indication. In here, the tonsil acts like a septic focus where it causes remote infection like the TB lymphadenitis or the glomerulonephritis. Also, the tonsil might be removed as a part of another surgery like the uveopalato-pharyngoplasty and the glossopharyngeal neurectomy, and in cases of the Eagle syndrome. For contraindication, there is absolute contraindication where you cannot do the tonsillectomy for the patient now or forever, like the patient suffering from the bleeding tendency, like the patient suffering from the clotting factor mechanism, or the purpura, or the hemophilia. So you cannot operate upon those patients. While there is relative contraindication, it means there is some sort of obstacle. You cannot operate the patient right now, but you can correct the obstacle and operate upon the patient later on after the correction of the problem. Like the patient suffering from acute attack, it's better to give him medical treatment till the correction of the case, and then you are ready to operate upon him. Or the patient of the quinsy or the peritonsillar abscess, it's better to incise the abscess and drain and give the patient some time for the ratio for the tissues to rest, and then it's time for the surgery and the removal of the tonsil. Also, during the epidemics or during the menstrual cycles of the females, it's better to give the patient some time. For the investigation preceding the surgery, they are divided into the acute phase reactant like the ESR, erythrocyte sedimentation rate, or the C-reactive protein, or the antistreptolysin autotr, and all of them are being done to make sure that the patient is not in an acute attack. After the acute phase reactant and getting the patient ready for surgery, you have to detect the coagulation profile of the patient, making sure that your patient is a good candidate and he is not suffering from any clotting factor defect, like the prothrombin time and activity, the activated partial thromboplastin time, and the bleeding and clotting times. For complications of the tonsillectomy, it might be complications of the general anesthesia, respiratory complications, which represent the most serious complication. They might include the falling back of the tongue or the vomitous aspiration, the hemorrhage, which may be one of the following types. It's the primary hemorrhage encountered during surgery, reactionary hemorrhage that might take place within 24 hours of the surgery, and the secondary hemorrhage, which is mainly caused by infection. Otitis media, edema of the soft palate, and dental injuries also one of the complications that might be taking place following tonsillectomy.